So welcome everyone to our first episode of Menopause Musings. And today we've got myself, I'm Dr. Farhat Udin, menopause specialist and GP, and the lovely Rachel Brown. Rachel, tell us what you do.
Thank you. Hi, Farhat. So I recently joined Farhat to work alongside her in the clinics. I'm a GP. I've been working in Bristol for about 30 years, and I also work in the complex menopause clinics at one of the local hospitals where we see lots of patients with menopause symptoms plus other medical conditions or a history of breast cancer and so on. So lovely to be here today.
Amazing. And that brings us nicely onto our topic today. So talking about complex cases, migraine and menopause, a really complex, but really common problem that we see. And lots of these women, some of them don't know that they're having migraines. Lots of them having migraines for the first time in midlife, or some of them have had migraines before and they get a lot worse. Maybe they get longer, maybe they get more severe or treatment resistant during midlife. And yeah, so I think we need to unpack this a bit and find out what's going on and what we can do to help these women.
Yeah, so how about we start with talking about what the stages are of migraines? I think actually getting the right diagnosis is important, isn't it? But understanding what it feels like to have a migraine. I don't get migraines. Do you?
I don't, but my
No.
other half does.
Right. Okay.
And it's really interesting because I was reading
Yeah.
up on the stages of migraine, and I didn't realize that he definitely gets the first stage. And the first stage is the prodromal stage, and it can be irritability. So I have noticed that actually just before a migraine, he does get quite irritable. So it will make me think now, what's about to come. But yeah, so stage one can be, and not everyone will have all the stages. There are 4 stages that we know about in a migraine. But yeah, some people will have them all, some people will have 2 or 1. But the first stage is the prodromal stage, which, as I said, can be irritability. It can be just tiredness, yawning, neck stiffness. Some people actually get a burst of energy in the prodrome, which is interesting. And then we go on to the aura phase. So about 25% of migraine sufferers will have aura. And typically an aura will start before the actual headache. It lasts up to an hour, and it will resolve before the actual headache stage itself. And the most common aura we see is a visual aura, and it starts centrally, and that can be zigzags or flashing lights or sometimes blurred vision. Occasionally, it can be other senses as well. Sometimes people can smell burning, or it can be an auditory sensation as well. And then that takes us to the third phase, which is the headache phase, also known as the impact stage, because it's not just always a headache, it can be the dizziness, it can be the nausea, the vomiting that impacts a person in this stage. And I think migraine is, we really regard migraines as a more severe headache, unilateral, which means it's one-sided. Not always, but typically we do see it one-sided, and it can often be a really pulsating pain. And that can last anywhere between 3 hours and 72 hours. And the other telltale sign that's a migraine is it usually inhibits you're able to do your daily functions. So people will normally say to me, I just want to lie down in a dark room. I don't want to move. Moving makes it worse. Climbing stairs will make it worse. So it inhibits function. And I think that's how you know it's a migraine. And then there's the 4th stage, which is the post-dromal stage, and that can be up to 2 days, and you're left with grogginess, brain fog, just a sense of not being able to think clearly. So it can be really disabling, and if you think about that's up to 5 days. A migraine can last 5 days, and if you have a couple of those in your month, that's a big chunk of your month just gone.
Pretty awful, isn't it?
Pretty awful. Yeah. Yeah, I mean, so I don't suffer with migraines either, but I've heard there are different types of migraine as well, aren't there?
Yeah. So you mentioned there that about 25% tend to get an aura, so the majority don't get an aura. And then the most common type is the actual headache that you've been describing, but there can be other symptoms as well. So some people get what's called a vestibular migraine when they get dizziness, which can be really quite debilitating and mean that people again need to spend a lot of time lying down and not being able to do their normal working day. And then you can get other sort of atypical symptoms. So you can get some motor symptoms. You might get some weakness or some pins and needles sensation in some of your limbs, and so that can sometimes be worrying for people because they think it might be a stroke. So
Yeah,
it's
that
important
sounds
to get the
scary.
right yeah
Mm.
important to get the right diagnosis. Some children can get what's called an abdominal migraine. So when they
Mm.
get a recurrent tummy pain, and that can sometimes be quite difficult to diagnose, but it can be associated with school anxiety and other sort of causes like that. And then there are the different ways of sort of classifying the timing of the migraine. So commonly they're episodic. So some people will say, well, I get them sort of once a month, twice a month, something like that. Some people get chronic migraine, which can last for a long period of time. And then obviously what we're most keen to talk about today is those that are related to hormones. So you can
Yeah.
get a migraine with your periods. Um, Things can change during pregnancy, and then in the peri and the menopause itself, that can lead to changes as
Hmm.
well. So I guess that leads us quite nicely on to talking about the causes of
Mm.
of menopause, causes of migraine, and where
Mm.
hormones fit into that. Um,
Mm.
what are your
Yeah,
thoughts about
it's
that?
interesting, isn't it? So yeah, we definitely see those premenstrual migraines and those menopause ones. I think, so we know, Rachel, that it's to do with our genes. So it is migraines are genetic, and I think whether a person gets migraines is also dependent on their internal environment and their external environment, how these environments interact with their genes, something we call epigenetics. So at any one time, different genes can be switched on or switched off. And we think there are about 40 genes that are expressed that are involved in the migraine pathway. And the brain loves a steady state. So the migraine brain loves a steady state. So anything that fluctuates in the brain, be it blood sugars, be it stress hormones, can trigger a migraine. And hormones are one of those things that definitely we see, don't we, triggering
Mm,
migraines, those
definitely.
fluctuations. Um, so yeah, I mean, perimenopause, like you said, menarche, pregnancy, those are all times of a woman's life that her hormones can fluctuate wildly, triggering one of these migraines. So yeah, that's definitely one of the causes. I mentioned blood sugars. I mentioned just stability. So regular exercise is really important. And I think you're going to talk about lifestyle in a bit, but just keeping, again, I think with exercise it is tricky because sometimes that can lead to blood sugar dips as well. So eating correctly when you're exercising is so important. But yeah, overall, I mean, it's quite a complex condition. We know that there are electrical changes that go across the brain when we have a migraine. And the type of migraine actually that we have is determined by where in the brain those electrical changes are occurring. So it could be in the cognitive region, which gives us more word finding difficulty or problems thinking, like I am now. Um,
Mm.
or it could be in the visual cortex, which gives more of the visual symptoms, or often in the other cortexes where it can cause problems with limbs. So it's a really interesting condition, but very
Mm.
complex.
Mm.
But yeah, I mean, so hormones, going back to those, we that's the area that we specialize in. Um, and it's so it can be quite frustrating actually, because I don't know about you, but I've seen women that have come to me and they've been told that they can't have HRT because they have aura with their migraine.
Mm.
And some of these women are really struggling and they've been denied any kind of hormones to help. And so, I mean, what is that about? And is that true? Are they not allowed to have HRT?
No, so it's not true, and it's as you say, it's a very common misconception, and I think a lot of GPs are are lacking in confidence and a bit confused by HRT generally and the doses that we use in HRT. So we know that The combined pill and HRT are completely different doses. With HRT, it's physiological doses, and with contraception, it's much, much higher doses. So categorically, the answer is yes, women who have aura with migraine can use HRT. We do know that migraines with aura does put you at a slight increased risk of stroke. And that's where the concern comes from. So those women are advised they can't take the combined pill, but they can use HRT. Um, Obviously, it's really important that we make sure that we're managing the other risk factors that might be associated with stroke. So thinking about stopping smoking, making sure your weight is optimized, and that other health conditions are optimized as well, such as high blood pressure and diabetes and heart disease and so on. So I think so in the perimenopause in younger women, it can be a little bit complicated. If they don't have an aura, then they can take the combined pill. And sometimes it can be helpful if they're beginning to get worsening migraines because their hormones are going all over the place, then it might be useful to take the pill back to back without a
Mm.
break. And you can do that for a reasonable length of time without it being problematic. And also, some women might want to try the progesterone only pill because that might be better at sort of stabilizing the hormones and also stopping bleeding. When we think about starting HRT, we would always think about starting at the lowest dose possible with migraines, with any risk factors, and we would increase it gradually and slowly. So usually sort of every 3 months or so. The BMS, the British Menopause Society, recommends that transdermal HRT is best for migraines, and generally the guidance is to use a continuous form, so using estrogen and progesterone every day rather than a cyclical type. That doesn't suit every woman, so younger women who are still perimenopausal might find that causes them to have irregular bleeding and it's quite problematic. But generally, most of them will tolerate a combined form of HRT. And the benefits of that are hopefully that you won't bleed. So that's a win-win.
Yeah. Yeah.
Um, so just thinking about the types, as I said, we would aim for a transdermal form. So that can be patches or gel or spray for the estrogen. And then for the progesterone, it depends on what the woman would prefer to do. The Mirena is everybody's best friend. It's the best thing
Yeah.
in terms of progesterone. It stops you bleeding. It's the easiest thing. It lasts for 5 years and is, well, I recommend it all the time, and that's very, very safe. That thinking about other progesterone options, utrogestan, which is probably the most popular form of progesterone at the moment used in HRT, tends to work well. And there's some evidence that actually it enhances the GABA activity in the brain, which is involved in migraine, so might be particularly helpful.
Yeah. And
So I
helps with
think,
sleep. Yeah.
yeah, absolutely. So I think, if people are finding that they're not getting what they need with respect to HRT, then that's where we can step in and actually give some evidence-based guidance and hopefully get women on a regime that suits them well.
Mm.
We do know that some women's migraines get better with HRT and some get worse. I mean, it's a confusing thing, isn't it? I mean,
Yeah. And that was so just going back a little bit, you mentioned the contraceptive pill. So that's a really good option, isn't it? If women are
mhm.
under 50 though. So once they hit 50, we can't prescribe that
No,
anymore. And
no,
that's when we would be thinking about the HRT.
yeah,
And but again with the contraceptive pill, if they've had aura, we're not able to prescribe that, are we?
no.
Okay.
Mm,
Yeah, so there are lots of options, and I think it's what from what I'm hearing, it's keeping those hormones stable is the key, and giving women that steady state of estrogen can really help with the with preventing migraines. Hence the continuous methods, continuous combined. Yeah, so I really love the Mirena. I think it's a really good option because it does stop the bleeds, and you also get a continuous level of progesterone, which is really nice. And the other thing that I've come across was, and it is off license, but desogestrel,
mm,
so doubling the pill. It's completely off license, but we do it, don't we? Can
Yeah.
be can be another option. So if you're struggling with the different progesterones and you don't want the Mirena in, there is, yeah, that's an option that I've used a few times, where we double up on the mini pill, and it's quite good at switching off ovulation, so we don't get those ups and downs in
Yeah.
hormones.
Yeah.
Yeah,
Just thinking about things being licensed. So HRT isn't licensed to use to treat migraines in menopause, but obviously we can use it as part of HRT to enable that. So we wouldn't use it first line as a treatment, and we're going to go on and talk about treatment a bit later on. But for any woman during the menopause who's got migraines, it can be revolutionary in hopefully stopping the migraines.
definitely. Yeah, definitely. It's definitely, when I see a woman in midlife and they're getting worsening migraines, or they're getting new migraines, the first thing I will try and do is balance their hormones. And it might be that, when I see a woman, they're not ready to start HRT, they want to wait until maybe they get more menopause symptoms, and that's completely fine. But I think, as clinicians, knowing what we know, we always offer it, don't we?
Hmm.
Because it's important to make an informed choice and know that balancing your hormones is going to help alongside other migraine treatments.
Yeah.
But it's such an important part of migraine in perimenopause to get those hormones nice and smooth.
Hmm.
Yeah. Yeah, so you did mention that some people seem to get better with HRT, but some people get worse. It's interesting, isn't it? How we're all very individual, and I think, hormones definitely affect us all differently. But I think we know that migraine with aura tends to be more sensitive to rising levels of estrogen,
Yeah.
whereas migraine without aura tends to be more sensitive to either decreasing or fluctuating levels of estrogen. Which is why I think what you were saying before makes a lot of sense. How we increase the estrogen very slowly, start off with the lowest possible dose for a woman, especially if they've got aura, and then we gradually increase it to a dose they can tolerate. And most women, once they've got a steady state of estrogen, tend to be fine.
Mm.
It's those fluctuating up and down levels that cause the migraines. Um, yeah, and then there's progesterones as well. We see sensitivity to progesterones. So again, a steady state of progesterone is really important, if at all possible. So the Mirena is a great one. But certain ones do seem to have different effects on women. And
Mm.
I know there's two recently licensed progesterones for HRT, drospirenone and dydrogesterone, and they both look quite promising as progesterones to be used in migraine as well.
Yeah. Yeah.
Yeah. Um, but yeah, essentially, I mean, my advice is, if you're getting new headaches in the perimenopause, it's likely to be migraine. But we do, we do need to exclude other causes. So it's really important to get your blood pressure done, to get blood tests to rule out anemia. So getting a really good blood screen at that point. Um, and then just remember that, if that our menopause symptoms generally can increase the risk of migraine. So if we're having symptoms like poor sleep or hot flushes, controlling those can also prevent our migraines.
Yeah. Yeah. Absolutely.
So there's a lot to it.
Indeed.
um, and not forgetting lifestyle, because I mean, we've talked a lot about the medication side of things, the hormonal medication side of things. But I always say that, there's no point in taking HRT if we haven't addressed the lifestyle side.
Absolutely. Yeah. Yeah. And it's really the paramount um, area to focus on before thinking about HRT. So I would always encourage women to make sure that everything is as stable as it can be in their life. So focusing on their diet, their sleep, their exercise regime, and making sure that they're similar each day, to keep things as smooth as possible and hopefully get those hormones nice and regularized. With respect to diet, it's really important to have a think about what the precipitants might be for some women. So certainly some women find that migraines and indeed flushes and other menopausal symptoms can be worse with caffeine and with alcohol and with smoking. So we would generally encourage trying to avoid those if at all possible. And then thinking about how to manage your stress, which we know is really difficult on a
Mm.
day-to-day basis for everybody, but thinking about other things that you might do to stabilize that. So trying to find some time for you during the week when you can do some yoga or some mindfulness, or do some mindful walking, whatever fits for you. I try to get to the allotment just when I can, because it's a really peaceful place, and I try and make sure that I can factor in some yoga and some walking into my daily routine. Sleep's really important. We all know that we feel rubbish if we haven't slept well, and you're more likely to get a migraine if you haven't slept well. So just making sure that you do everything you can to optimize your sleep as well. There are also some supplements that we know can be beneficial for women when
Mm.
they've got
Yeah.
migraines, and are particularly helpful with the menopause as well. So just thinking about the migraine specifically, there's some evidence for coenzyme Q10, and I think the dosage is sort of 150 milligrams a day. You'd need to buy that from a health food shop or a regulated supplier. And then magnesium that we use quite routinely during HRT consultations to help with sleep, and also with gut symptoms. So between 300 and 500 milligrams of magnesium. Magnesium glycinate is the one that's thought to help most with sleep, and I tend to get the most success with patients using that.
And the least side effects.
Yes,
Don't get
yeah.
the diarrhea.
Yeah. And then there are some other vitamins. So riboflavin, which is vitamin B2, there's some evidence for that, and around
Mhm.
400 milligrams a day. You can obviously get a lot of these within your diet, but sometimes it's worth adding in some of these supplements. If you're going to do it, then I generally suggest to women that they try adding one at a time, and they do it for a month at least at a time, and that they try also using a symptom diary, so that they can see whether it benefits them or not, because a lot of these supplements are quite expensive. So,
Mm.
don't take anything that doesn't seem to be helping you. Um, and there are lots of diaries available for migraine sufferers, which are really useful just to try and work out what might be making your symptoms worse. So it's worth having a look at some of the websites for that. Just thinking about two other supplements. The vitamin D, we would always recommend for all women, at a dose of 1,000 international units. That's really important to help with your bone strength, and living where we do. We know that vitamin D is really important. And also omega-3, you can get that in fish oils, but there is some evidence for benefit with that too. Um,
Mm.
and as I just mentioned, linking in with some of the migraine charities can be really, really helpful. I had a quick look this morning. There's a lot of information on the National Migraine Centre. There's lots of useful resources and also some podcasts. And there's a section on women's health. So do go and have a look at those. And they've also got some diaries as well in their resources on the resources page. There's also the Migraine Trust, which again has got a lot of useful information. And there's also sort of menopause and migraine related information on the NICE website, and also the Women's Health Concern, and Menopause Matters. So there's lots of useful information out there
Support
that is
is, yeah.
accurate and supportive. Um, I guess what we've been focusing mostly on sort of HRT, but alongside HRT, obviously women will be considering the normal treatment for migraines, and it might be that they don't start getting migraines until suddenly in the perimenopause. So it is important that we address that issue as well. So can you talk us through the acute treatment, the sort of emergency
Yeah.
treatment for migraines?
Yeah, definitely. So thank you for talking about lifestyle. I just wanted to add to that. Just focusing back on nutrition for
Mm,
me is a really important one. And it's interesting. I had a lady who was wearing a continuous glucose monitor, and she found that was really helpful with her migraines because she
right,
could
yeah.
see that the dips in her sugars,
Mm,
what would cause a dip, and that always seemed to correlate with a migraine. And we sort of looked at her diet, and adding more protein, adding good fats and more fiber really was like an essential part of her diet. So yeah, just to reiterate how important controlling, trying to keep your blood sugar stable is.
Yeah, absolutely.
Yeah, but you're right. So I mean, yeah, with all the will in the world and all the best lifestyle choices, and even once we've got our HRT in, it's still some of these women are still struggling and will get migraines. And I think it's very, very important to have your acute migraine treatment ready, easily accessible, because what you want is to be able to nip these migraines in the bud. The earlier you can treat them, the quicker you can get it into you, the shorter these migraines will last.
Yeah.
And the less disabling they'll be. So I see migraine, the acute treatment, and there's three parts that I see as important. So you've got the first part, which is actually anti-sickness tablet. And the reason it's so important isn't just for nausea, but it's also because of gut motility. We know that when you have a migraine, your gut motility slows down, and the antiemetics we prescribe actually speed up gut motility and help us move the gut on, absorb those painkillers. Otherwise, giving an aspirin or some ibuprofen to a gut that's very slow means it's not going to absorb anytime soon. So the anti-sickness tablet to get your painkillers into you, the painkillers themselves. So ibuprofen, maybe 400 milligrams. Some people need 600. Soluble aspirin, about 300 milligrams. Paracetamol can also be. I mean, it's not as good for migraine, but it can work for some people when it's combined with an anti-sickness. And then thirdly, the triptans. So they are an acute migraine treatment. There are different types. There's a tablet, there's sublingual under the tongue, there's the nasal forms where you can spray it into your nose, which can be quite fast acting. And I think there's also newer treatments that also are comparable to the triptans, like G-pants. So I've not prescribed those yet. Have you?
No, I haven't. No, I was
No,
reading up about them. They sound, quite revolutionary. So hopefully
they
they'll be really
do.
helpful. I was just going to say, I was looking at some podcasts yesterday, and somebody described the acute treatment of migraine as being like using a fire extinguisher on a fire that's in a bin in a room. So you need to put it out very quickly before it explodes into being really problematic. And obviously that's the best thing to
Yeah,
do rather than
yeah.
it getting worse.
Getting less. That's a really good analogy. And
Mm.
I was listening to another headache specialist saying she actually recommends Coke. So having your acute migraine treatment with a can of Coke. So dissolving your soluble aspirin into the Coke will make it work faster because you're increasing the surface area of the aspirin. You're adding in caffeine, which is going to help with that gut motility. And the sugar can be really helpful if you're having a sugar dip, and that's contributing to your migraine, actually raising your blood sugars. So I wouldn't recommend, those
No,
big
not for
cans or those
everybody.
big bottles. And if you're diabetic, I haven't, ignore my advice. But I think, one of those small mixer cans as part of your rescue pack for your
Mm,
acute migraine can
yeah.
be really helpful.
Mm,
Um, but yeah, and I think also we're just remembering overuse as well. So we know that medication overuse can lead to chronic headaches as well.
mm,
And our advice is not to be using them more than 10 days in a
mm,
month. And that doesn't mean it's not 10 times, it's 10 days. So you can use your triptan twice in a day if you need to, and that counts as still as one day. So it's 10 days in the month. And if you're using it more than that, we need to be talking about well, yeah, but we need to be talking about prevention anyway. So yeah, prevention, I think definitely if you are having more than a couple of episodes in a month, we should be
yeah.
giving you something. And there are quite a few options, aren't there, when it
Mm.
comes to prevention?
Yes, I mean, as you say, if you're having more than a couple of episodes per month, it's so debilitating for these patients. It is, if we can get on top of it with some preventative options, then that's really good. So there are a number of sort of standard treatments that we can use in general practice, like propranolol, which can be used generally for blood pressure or sometimes for anxiety. So it's a great drug. We can use it for lots of different things. There's amitriptyline, which again is used for other types of pain and for occasionally for depression, but that can be helpful as well. And then something called topiramate, which can be used for epilepsy. So I think, if you're being offered these drugs, don't worry about the fact that they're generally used for something else. We do use them. They are licensed for prevention of migraine. And then there are lots of other sort of new kids on the block that are coming out. As you mentioned, perhaps there are these new GPANTs, which are they're a new class of drugs that target the calcitonin gene-related peptide protein, and that's believed to be what is the cause of migraine pain. So it looks as though those are going to be really helpful. And as we said, you can use those acutely and also as a preventer. And then it may be that you get referred to secondary care for those, but also some people find that Botox injections can be good.
Yes.
So it feels a bit of a rogue thing, but Botox can be used for quite a number of things as well as for sort of plastic surgery, sort of facial improvements, but it's worth considering.
It's your
Um,
wrinkles as well.
yeah, absolutely. Acupuncture works for some people, not everybody, but it might be worth considering. It feels a bit counterintuitive, doesn't it, to have some needles put into your
Mm.
face to help with pain that you're already getting, but it is evidence-based. Some people find nerve blocks can be quite useful too. And then there's this big class of drugs called monoclonal antibodies, which we use for an expanding number of conditions. They're a really exciting group of drugs. They're expensive, but they're transformative for lots of different conditions. And for migraine sufferers, we can refer for people to have these treatments. I think you need to have tried 3 other preventative measures before you can be considered for this. And it can be a monthly self-injection or an infusion. I think it may not be available in all NHS areas, so I think you'd need to check
Yeah,
with your
bit of a postal lottery
GP.
still.
Yeah,
Yeah.
which is unfortunate. And then there are some even more sort of wacky, innovative treatments. So there's some neuromodulation devices that sometimes work well. They use sort of electrical and magnetic pulses. So I think, the bottom line is there's lots of stuff out there
Mm.
to add into the normal acute treatment and also the HRT. So I think that the aim, hopefully, is that we can get our patients pain-free by this big armamentarium that we've got of different things that we can try. Um,
Definitely.
I think we've done
Yeah.
pretty well there to whiz through migraine in half
That
an hour,
was
haven't we?
a whistle-stop tour of migraine, wasn't
Yeah,
it?
yeah.
Yeah. So I think yeah, amazing. Just if you are struggling, if you're at that point in life, worsening headaches, and you are perimenopausal or menopausal, think hormones, um, reach out. There are lots of support groups. And Rachel, you mentioned the National Migraine Centre and the Migraine Trust for information on migraines, and obviously see your GP if you are struggling, because there's lots that we can do.
Yeah. And we're going to have some more talks on lots of other subjects in the next few weeks. So keep an eye out for
Yeah,
promotions on Instagram. Great to talk to you
lovely.
today. It was really
Great
nice to
speaking
talk
to
through.
you. Thanks, Rachel. See you next time.
Yeah, take care. Bye.
Bye.